Just wanted to welcome you all, first of all, to today's webinar, which is on how we can move from illness to prevention and the role of data and digitalization in supporting that shift. I'm Oliver Lake. I'm the Chief Executive of PRSB and delighted to be hosting the session today. Welcome to both our members and also our partners. We're running a series of these lunchtime sessions. We had one last week on AI and ambient scribes and how that might be a sort of key part of the technology of the analog to digital shift. And today's session is on one of the other shifts. I'm sure we'll do a session on the other shift, the neighbourhood shift as well, in due course. But welcome to you all and thank you for joining. If you can all remain on mute for the duration of the session. We will, of course, be doing questions later on, where we'd encourage you to take yourself off mute when you speak and use the chat as we're going through, please, to paste in questions. We'll come to those. I'll facilitate those after we've had the presentations. And the reason that we're doing these webinars is we've all now been in receipt and I'm sure have read the 10-year plan time and time again. But the question is always around, well, how do you make these things happen? There's some fantastic ideas, priorities, new directions of travel for the NHS set out in the 10-year plan. We're awaiting the implementation guidance that will come later in the year. I wanted to use these sessions by means of sort of trying to get some thought, some input into that implementation plan, and particularly for our members and for our partners who value high quality standardized data as part of that. What are the kind of key things that we want to influence and put forward as ideas for how we can make the 10-year plan a success? So delighted we have such fantastic speakers here today. I'll introduce them one by one and then we're going to move straight into the presentations. We have, first of all, Julie. Well, there you are, Julie. I can see you over there. Julie is Managing Director and Founder of Health Diagnostics, who are a PRSB partner and are involved in the world of the digitisation of NHS health checks, and an area particularly close to PRSB's heart, with the Department of Social Care on a new record standard for health checks, and actually we're continuing to do some of that work around eligibility over the coming months. So thank you, Julie, for joining us. Also introducing Dr. Abraham George, who is Assistant Director and Consultant in Public Health at Kent County Council. We're talking to us a bit more around some of the more kind of operational and as well as the strategic issues around joining up health, social care and other social determinants of health data. Sarah Arnold, there you are, Sarah, hello, who is a Senior Policy Lead at the King's Fund and has recently been writing on this topic based on her experience of working in the field. And finally, William Roberts, who is the CEO of the Royal Society for Public Health, and who, alongside the other kind of public health organisations representing public health professionals, after the 10-year plan, produced a response, but also has a more strategic view on the needs for how public health can be developed and professionals developed in the field. So really exciting kind of eclectic mix of views from our speakers. I think we're going to be doing a bit of zooming in and zooming out, both on the overall strategy, but also on some of the practical issues that will face us when we come to implement the changes. So without any further ado, I'm going to hand straight over to Julie, who's going to give our first presentation. People I think are going to speak for between 5 and 10 minutes, and then we'll be moving to some structured questions, and then there'll be opportunity for everyone here to ask questions as well at the panel. So Julie, I'll hand over to you. Thank you very much.
Okay, I'm just going to start sharing my screen. So can you see
We can see it.
You
It's
can?
not in presentation mode at the moment.
Yeah,
but,
I'm just about to do that, just
yeah,
making
amazing.
sure. Slides. Brilliant. Okay. So, yeah, I wanted to say thank you for the invite today and the opportunity to share my experience in the preventative healthcare projects that I've been involved in for over 40 years now. And I just wanted to start off with quite an unusual slide, because I bet you're all wondering about the relevance of the miners' strike in 1984. But back in 84, the police clashes with the miners during the strikes highlighted a real lack of fitness across the police forces, and it shone a light on the importance of being fit to do a job. So the Police Federation embarked on a programme to develop a national fitness testing and improvement programme. And a friend of mine who was a professor of physiology at Chester University was working with the police at that time, designing a fitness test to enable a cost-effective way of measuring the fitness of the police. And at this time, his system was a few printed sheets, a metronome, a gym bench, but the forces actually began to use it. And it was after many chats, maybe around the odd glass of wine, that the effectiveness and the potential to improve fitness generally was really becoming quite apparent. So in 1984, we started a business called FITEC, and that stands for Fitness Through Technology. Back in the sort of mid-80s, we quickly produced a commercial version of the STEP test, which was rapidly adopted as a standard across the forces in England and Scotland. Then over the next 2 years, we expanded the services, and we really started to include a wider range of tests, things like body composition, strength, flexibility, blood pressure, and moved into things like cholesterol, stress, etc. over time. But we computerized it really early on. In 1985, I had what you would class as a portable computer, which is the large one in the right-hand corner. I was so pleased when Alan Sugar introduced the new Amstrad Portable back in '89, because that meant I could travel the country training the police in order to deliver these tests. The computerized system gave printouts to the individuals, showed them their current results, and gave them a program of exercise geared to their age, sex and level of fitness, because the idea is not just have a one-off test, but what can we do to improve it? We need to get you fit to do the job. The system was soon adopted as a standard in the fire service, the prisons, the RAF. And over the following years, we started to supply companies across the UK to deliver workplace health check programs and leisure services. So interesting just to look at the key points of health in those 40 years since I started. Over that period, since 1985, the levels of obesity being recorded back in then was about 8.5% of the population. Over the next 20 years, it reached nearly 24%, and now it sits around 26.5%. And that we know that being overweight or obese is a real considerable risk factor for developing type 2 diabetes. And the links are clearly seen, because you can see from 1996 to the present day, we've gone from 1.4 million to 4.8 million diagnosed. There's still about 1.3 million undiagnosed, which were at an all-time high. So despite having all these programs and projects on the go, the figures are just going up. So we do know that it's impacted by so many other determinants of health. So from the early experience, I formed a new business in 2003 with Health Diagnostics, and we were really looking at a wider health and wellbeing offer. And because I'd worked with the police, it was a natural sector to revisit. But we also got into the high street pharmacies and other organisations. In 2009, we were really excited because the government launched the NHS Health Checks programme, and we were really well placed to jump straight into that. And we've supported over 70 local authorities and the Welsh Health Board with their equivalent of the health checks over that period of time. We were also approached in 2016 by NHS England for their workplace health checks pilot. And again, more recently in 2024-25, we supported a number of local authorities with their workplace health checks pilot that's just recently ended in May. So what's it like at the coalface? Pardon the pun from my miners, but one of the first large projects we worked on was the London Met Police, and this became a gold standard for prevention in the police force in the sort of early 2000s. The data gathered is referenced in the government's Windsor report of 2011. And we provided the Met Police with the software solution, the testing equipment, the training, the analytics and the support in order to them to deliver a very mobile service across London. Instead of bringing the staff to the Ock Health Department in Earls Court, 2 vehicles that you can see in the top left there went round to the 32 boroughs in London and delivered 30-minute health checks with minimal impact on police time, and they delivered over 12,000 health checks in each year, and this was achieved with a team of about 20 staff made up of VOC health nurses and physical training instructors. The results were published for the 2 years of the programme. Huge savings, 30 million saving in the 2 years by focusing on the health and fitness of its employees. They reduced sickness absence by 3 days, which essentially had an impact of £10 million a day. This was enough to cover the cost of sick pay. It was estimated. They thought that 30 million was probably an underestimate as well. With the NHS health checks over this time, over the last sort of 15 years, we've had fantastic programmes. Durham County Council achieved a significant increase in uptake in their programmes when they aligned their GP and community outreach models. It went from 38% to 63% uptake over a 5-year period that we were involved with them. More recently, Medway Council Community Team has their outreach team and the outreach approaches deliver health checks in such a variety of settings. They've even got a high street shop. They recently showed a 10.5% reduction in CVD risk scores in the 12 months following the health check. And Merton Federation are achieving 100% completion rates, so reducing the number of incomplete health checks, and it's the first time that that's been achieved. On the workplace health checks, the figures just keep coming out. Sheffield were one of the 4 projects we worked with, the hospitals there, and their sickness absence was down 10%. It was the fewest days lost in 5 years. With York, 80% reduction in CVD risk, an average 4 centimetre reduction in waist size when they were measuring them, and a 4.2 millimetres mercury reduction in systolic. So, and the fact that York Teaching Hospital were also the 2021 winner of the Occupational Health and Wellbeing Awards for the Best Wellbeing Initiative, because all these projects continued using our services after the pilot ended. But despite repeatedly demonstrating the measurable benefits, including the return on investment for preventative programmes, most programmes ended due to lack of funding. I just wanted to share a few things of what these projects all had in common. The consistency and quality of the data was absolutely key, and having a view in real time of the analytics, the data that's coming through, enabled a proactive approach to the management of the programme. So if certain individuals weren't coming in, it could be seen, so they could parachute teams into different areas. So good quality and consistency of data is absolutely essential. The projects we work with tend to have a very strong leadership and a great support team as well, with a clear vision and plan. A lot of the projects have a good brand identity as well, because there's been a lot of issues with people not realising they've had an NHS health check. They may have visited the GP and it was done, but they weren't aware of that. So usually a strong brand identity, people then trust the brand, knew what it was about. So that has helped. And then investment in sort of behavioural change-led consultations. It's the patients who need to understand the impact on their lifestyle. So there's no point in just going through a tick box exercise and gathering data. You have to share that information, and they have to be able to understand what small changes will make big differences to them. The mobility has been a key thing in these projects, getting the systems out to the targeted populations, including the workplace, at convenient times and locations, really embracing the third party teams, strong community teams, delivering in community hubs, and making sure the data all gets back in a timely fashion to the GP practice. I think the challenges going forward is we've got to stop reinventing the wheel. There are so many evidence-based solutions available out there, and there's evidence and return on investment is out there. We need to sort of look at that and embrace it. Having access to patient data to really enable targeting the most vulnerable populations and encouraging that engagement is a key thing, and that can be quite slow. A slow process we've experienced. The data quality and consistency is really key, so that's why we were so pleased when we saw the standards coming out through the PRSB, and kids are very keen to see those being adopted. Interoperability to ensure all data goes back onto the patient record, because that is key to making sure these projects are evaluated and measured and doing what they're meant to do. Accessibility with the tech, and the tech should be a support tool. it shouldn't become a burden. I can see a lot of people struggle with tech, so it's making sure that it's intuitive and not over complex. And who's going to follow up any health issues that are discovered? The GPs are already stretched, so they could. Should there be community hubs, mobile prevention hubs that can offer additional help, including things like fall prevention, healthy eating? And we do think it's the start of the journey, not sort of a one-off. Many patients are asking us about follow-up. So having the positive impact of change can be maybe measured through apps, wearables, self-service kiosks, self-assessments. But this all, again, needs some sort of integration, whether that's the single patient record that everybody's talking about. And we've got to really provide the long-term impact of these programs so we actually secure the funding ongoing. So those are my findings, and I hope you found that sort of helpful.
Thank you very much, Julie. And I'm sure we'll be coming back a bit more to the kind of like the business case for public health. There's always a strong business case, but it never quite. I always feel that there's more that could be done, and you stretch a bit further, you get a greater impact. But of course, what sits behind that is the data, and how do you prove that the interventions that you're making are delivering those outcomes? We'll revisit that in a little bit, but thank you very much for now. I'm going to hand over to Abraham. Thank you very much, Abraham.
Thanks, Oliver. So for those who don't know me, my name is Abraham George. I'm a consultant public health at Kent County Council, and we're a sort of a big public health team led by consultants, and we all have different portfolios. My portfolio is mainly around leadership for data and intelligence, and also for building up the research evaluation sort of function in our department, as well as for the wider council, and also for education and training. So it's the data and intelligence bit, I'm presuming, which is of interest in today's discussion. So I think what Julie has presented is really useful and puts a good preamble in terms of what my particular interests are in terms of the data agenda. So the sort of background that I come from is particularly around the development of locally linked data sets in Kent, and how we've been using it for advanced analytics, namely things like risk stratification, service evaluation, and also system modeling, which at the moment is a particular importance for us. As some of you may be aware, there is a statutory requirement for councils to actually come up with regular production of population health intelligence called JSNA, or Joint Strategic Needs Assessment, which I'm the consultant lead for. I think what I wanted to just quickly add, and I'm presuming I've only got a few minutes left to talk, which is just raising awareness that actually a lot of the data that we've been using, particularly for healthcare commissioning, has been largely data from the NHS. So that is data from general practice, data from the NHS trusts, and more recently that's been more readily available in an integrated manner through shared care records across different parts of England, which is really a great progress for that. However, what we really need to bear in mind are several other things. One is about the broader purposes of data, not just for direct care planning, but also for secondary uses or for analytical purposes. And putting on a commissioner hat, we need to be thinking about how we can use data in a much more robust way, not just about describing the problem in the population or in terms of population health needs, but how we can use data to actually help construct solutions. And I think that's the challenge that we're going to be having around how we can, in terms of what are those sort of greater uses of data. So that's one challenge. The other challenge is that actually, while the NHS collects fantastic amounts of data in terms of improving patient care, what is more apparent nowadays is that actually there's a greater awareness around the impact of health inequalities in terms of delivery of health services, particularly inequalities that are driven by socioeconomic factors. And those socioeconomic factors in public health terminologies are normally coined as wider health determinants. And a lot of them, for so many years, we've been using propensity scores or spatial to actually measure factors. So there's something like, for example, index of multiple deprivation. So that is available to us, but actually it's what's becoming more apparent is that it's too high level to actually make real nuanced decisions on commissioning and planning. And actually, what we just need to bear in mind is that there is other data sets that are outside of the NHS that we should be thinking about in order to help us improve and ameliorate our analytical capability, namely data sitting in councils, district council, as well as county councils, as well as unitary authorities, and data, very importantly, data sitting in voluntary organizations who have a tremendous role to play in terms of prevention for population health improvement. So, so I think it's those kind of data sets, that services that they deliver, as well as data on protected characteristics. So, and that's based on the equality and diversity legislation. We're very good at collecting data on ethnicity, but ethnicity is only just one of 8 or 9 factors that we need to be actually collecting, and we need to bear in mind who is actually and how is that data being collected elsewhere. And then finally, data on inclusive health. So there are lots of vulnerable groups in our population, ranging from looked after children, sex workers, veterans, gypsy Roma travelers. So all of these kind of different groups of population are all having specific health inequality issues. So how do we actually understand the impact of health inequalities for population health improvement for those groups? So I've written a few papers around this, and actually I can share it in the chat if people are interested in background reading. But I think, Oliver, if you're okay with that, I can stop there to allow others to sort of speak their contribution.
That's great. Thank you very much, Abraham. Yes, if you can share the papers, I think that would be certainly of interest to people here. And we can also add it onto our social posts after the event as well. So thank you. We'll do questions in a little bit, but I'm going to hand straight over now to Sarah. Thank you, Sarah.
Hi there, thanks for inviting me. My name's Sarah Arnold and I work for the King's Fund, which, if people aren't familiar, is a think tank working to improve health and care in England. I'd like to talk a bit today, kind of maybe zoom out a little bit. So this government has said prevention is one of its important areas of focus, but governments over the years have been saying that, and they've been enthusiastic about the potential, and that action really hasn't, well, it's really just been more rhetoric than action in many cases. So I'd like to talk about some recent research that I and some other colleagues have been doing into the opportunities and barriers to prevention at national and local level, and then a little bit about the current government strategy or approach and whether we at the King's Fund think it will actually be any different this time. So briefly about the research. I've been conducting at national level, interviewed a range of prevention experts and people working in NHSC and DHSC to understand the opportunities around prevention and why there's not been more action previously. And then locally, some of my colleagues have researched with a few ICSs and ICBs to build up a picture of the work happening in CVD prevention specifically and the barriers encountered in taking this work further. And I think there's 6 areas I'd like to pull out from our research. So first is a lack of agreement about what prevention actually is and what it's aiming to achieve. So we found really different understandings between different actors and sectors. For example, those outside the NHS we talked to generally seem to view primary prevention to be activity focused on the social determinants of health to reduce or prevent exposure to risk factors. And secondary prevention was looking at early disease detection. Whereas if you talk to people within the NHS, they generally seem to view secondary prevention as activity in the NHS and what the NHS does, whereas primary prevention is basically anything done outside the NHS. So that might seem like a bit of just an academic or semantic difference, but I think it's a problem because it often feels like people are talking at cross purposes. And that can mean that activity isn't coordinated or optimal from a cost-effective population health perspective, and there may be gaps in activity. A related issue is a lack of clarity on the goals of prevention and what it's trying to achieve. Is it about reducing demand on services? Is it about reducing early mortality? Is it about improving healthy life expectancy? Different interventions are more effective at different outcomes, and national leaders in particular told us it felt like the goalpost shifted quite regularly, which makes it very difficult to plan. So a second issue is accountability. And I think there's real questions about who's responsible for preventive activity and how are they held to account. And I think that's a particular concern at the moment, given all the reshaping happening at national and local level. So on responsibility, for example, I heard Dr. Vin Dewaka questioned recently at the Science, Innovation and Tech Committee. And he stated it isn't decided yet where digital transformation roles currently sitting in NHSC will end up. Are they going to go to DHSC? Are bits going to be devolved to locally or some other level? And the ambition seems to be to put as much as possible on the front line, but there'll still need to be some kind of higher level coordination. And I think there's a risk that some of that skills or coordination is going to get lost. And then on accountability for ICBs, and the NHS in general, actually, there's a huge current strong top-down pressure on issues such as waiting times and finances, but metrics around prevention seem much less kind of high level, much less focused on, and I think it can lead to some local leaders feeling pressure to prioritise other things, and there isn't really a strong sense of mission or energy in this space. So a third issue is funding, which is an issue at both the national and local level, obviously. But I think it's notable that between the Comprehensive Spending Review and the 10-year plan, there's clear earmarked funding for 2 of the 3 shifts. Hospital to communities, backed by a commitment to increase the proportion of funding going to community. Digital is backed by a £10 billion digital fund. Prevention really hasn't had the same kind of injection of cash or promise there. So in some ways, obviously, kind of digital tools can enhance prevention. So there's ways of kind of having that money from elsewhere, but it's not kind of backed by that same level. And we saw that at a local level, it's a particular problem, and this is obviously well known, that many interventions are reliant on small, non-recurrent funding pots that systems have to bid for, often at short notice, often in competition with each other, and that really makes it difficult. So I'd just like to touch then on the 3 other things which are more, I guess, focused on kind of digital and tools, so hopefully really relevant here. So in our research on CVD, that we found that many ICBs and GPs weren't really making the best use of existing available data and tools. So there's some really good tools, CVD Prevent, CVD Action, that have been developed to make it easier to identify patients to target and to optimise treatment, but they weren't being taken up very widely. And every time I've heard Wes Streeting speak recently, he's repeated the phrase, the NHS has more pilots than British Airways. And that sounds snappy, but it's also in many ways quite true. And I think particularly in prevention, there's a huge number of evidence-based interventions and tools that already exist. The focus is on how to make them spread. Or the focus should be on how to make them spread. I'm not sure whether it actually is. So 5th, and this is, I think, a really important part of spread, it's not just about providing tools, it's also about skills and local leadership. So you can have all the digital tools in the world, but staff need the skills and capabilities and confidence to use those tools. And local areas in particular need the operational management capacity to support with the nuts and bolts of implementation and the analytic expertise to work with data. And then finally, again, you can have all the data in the world, you can have identified things, but there's also a need for integration and to work in partnership. So we found, or we know that you can have the greatest impact at population level if you focus resources at high-risk communities, and you can use risk stratification tools to do that, to identify target groups. But you also then need to actually then engage with people. You need to strengthen links with the voluntary and community sector organisations in order to kind of reach out to them effectively and work with place-based partnerships and work with local communities to understand local needs. So I think I'm running quite close to time. I don't want to go into too much detail of what's in the 10-year plan or things like that, but just to leave you, I guess, with the final thing is, I think the number one thing that needs to happen to make things, to make a real difference, is to have a strong vision and purpose for what prevention is for. And what was in the 10-year plan, I just want to read out at the final bit in the chapter on prevention is, in 10 years' time, we will have transformed the nation's health. We will have restarted progress on longevity and healthy life expectancy, and we will have begun narrowing the wide and widening health inequalities that unjustly divide our country. That to me is not very strong, talking of restarting progress, beginning to narrow, and this only in 10 years' time. So I think there needs to be much more strong ambition going forwards, and I hope to see that in implementation plans and wider plans going forward of a focus on prevention.
Thank you very much, Sarah. Brilliant input, fantastic. And yeah, we will revisit some of those things. I hadn't realised quite the language that had been used in those commitments. You can call them commitments, but we'll come back to you. Please now, our final speaker is William Roberts, who's the CEO of the Royal Society for Public Health. I'll hand over to you, William, for the last bit of input. Thank you.
Thanks very much. Thanks for having me today, everybody. I'm going to very briefly, I think, touch on 3 things, some of which some of our speakers have started on. I'm going to start just quickly with why I think data matters and why it's really important that people like yourselves are doing this work and driving this kind of agenda. For me, data lets you do 4 things. It lets you understand populations, so whether that's the population as a whole or groups within those populations, and allows you to understand what's happening for those people. That then allows you to think about what are the problems they're facing, but it also allows you to understand what impact you might have and what solutions might work. And then finally, it allows you to understand the outcomes you have. I'm probably more optimistic than most people about the opportunity that's presented, simply because if we look back at any point over the last 100 years, we've been trying to do this stuff for 100 years and we have had real success. And I think one of the challenges is often to think about when you get these big plans come out, people see them as binary success or failure, when actually what we see over a history of time is some winners, some losers, but on the whole, things either demonstrably get better or demonstrably get worse. And often those things getting demonstrably better or worse are driven by the extent to which you get winners and losers balanced out over a system. And I think that's really important because today's not the day for it, but if anybody ever wants to talk about the greatest hits and what we've done in terms of prevention over probably the last 200 years, I can bore you for England on that. So there's some really good stuff, and this isn't all just it takes 1,000 years. This is stuff that's happened within very short spaces of time in prevention. The second thing I think is really interesting is about targeting populations and data. And I think there's a challenge for those of you who work with data and work with IT and tech to work out how do you get a proportional level of data and evidence to make you make decisions. And that's a really big challenge for the sector. And the reason I say that is because, firstly, we know who gets sick. We know who we need to work with for just about the large majority of all of our conditions. Now, there are huge ways in which you can break that data down further. There are ways in which you can get into even more detail on that, but fundamentally, we know who it is. We know that if the inverse care law exists, we know that if you're sick and you're poor, you're less likely to be able to access that care and to be able to get better. We also know that there are certain conditions which propensate within certain communities. So actually, like, you can have as much data in the world, but fundamentally we know pretty much where we need to go to improve health as a nation in the UK. And so one of the challenges, I think, for those of you who are both developing data standards, creating tools to capture data, but those also analysing the data, is at which point are you confident enough to take a gamble and a bet on the thing that you need to go after? And for me, that's about thinking, where do you get the biggest gains in a system? So, for example, if you look at health checks, I love health checks. They're amazing. They're brilliant. Most of the metadata on that says that they seem to also completely eschew all of the other issues around poverty, which most screening tools tend to pick up on. There's lots of good reasons for that, which you've already heard from Julie today about where you take them, how you make them accessible. But what's fascinating is the single greatest benefit we could have is going back to the people who've already been diagnosed with high blood pressure on health checks. 3 million of them aren't on treatment. We know who those people are. We could do something for those 3 million people tomorrow. The question, therefore, is why don't we go after them instead of just going after new people to then do more testing, but not necessarily then converting them into treatment? Secondly, you've then got to make a balance in this about where do you target stuff at a population level, because it makes a difference. Smoking ban is an amazing example of that. The smoking ban works at a population level. It helps people overall in the population smoke less. It controls tobacco, therefore make it easier for people to give up smoking, making it easier for people to stay healthier because they're not smoking. But then there are other things where we know absolutely you have to be targeted. Aortic aneurysm screening is a really good example of that, where we know who's most likely to have it, we know where they're most likely to be, and we could go after those populations. And so the balance with your data of where are you looking at a population level solution versus where are you looking at a targeted solution. And then finally, to finish, 2 things to say on training and education. Firstly, we need to develop the skills. So we're really good at developing new tech because it's exciting, it's sexy, and it often comes with some budget. But at the same time, some of that 10 billion for tech needs to go into how do you develop the skills within the workforce to then use and implement that tech. That's really, really critical. And one of the big challenges we will put to the 10-year plan is how much of the 10 billion tech budget is going to be spent on developing the capability of the people who will need to deliver it. The second thing is to say data is really important, but people are more important. People deliver plans, plans don't deliver outcomes. Okay, so you can have the best plan in the world, but if you don't get the people who have to deliver that plan into place to do it, and that could be just having the right engineers on your product to be able to make it accessible, it could be about digital inclusion, or it could actually just be as boring as making sure the people who use your product and use your data actually have the skills to do that. And so there's something interesting about how do we also think about focusing on the people rather than just focusing on, if you like, the high level plans. So there's lots of great ambition in the 10-year plan. I think it could have a real chance to work. There are some amazing things in there. Ignore neighbourhood health at your peril. I think that's the big driver of change over anything else probably in this plan. Target populations, whether that's at a whole population level or at a local level. And finally, don't forget, people make plans happen, plans don't.
Thank you very much, William. And you've even made me feel tremendously optimistic from your talk there. Thank you. We've got a question now, which I'm going to place to each of the panel members. Whilst I'm doing that, if you do have questions that you'd like to ask the panel, please do pop them into the chat, and we'll pull those together and make sure that we get those answered for you. But my first question, which I'll just address to you in turn, is from your perspective, what are the critical enablers to be considered in the shift towards prevention? And I'll come to you first, Judy, if that's okay.
I think it's great to hear about all this exciting tech, as everybody's talking about, and it can gather the data. But tech, as we've said, is not always accepted by everybody. The use of smartphones, wearables won't suit everybody. So I think it's been sort of reiterated earlier, but I do think that we need to make it accessible is the key thing. It's got to be understood what the reasons are for these health checks. What are the benefits to the individuals? We do get a lot of issues with how the data is going to be used, who's going to access the data after this. So I think it's having that clear plan and people really understanding the reasons for whatever health checks they're going to be embarking on. And yeah, the targeting is absolutely crucial, because we find that all the time. We try and get people to target with the systems that we provide, but sometimes that's like too much hassle. They just want to maybe just get people and fill some of their appointments. So making sure you are going for the highest risk, maybe for CVD, highest potential for diabetes risk, etc. The information's there. It's easily accessible, but it's not always used. Sometimes it's easy because the people doing the sort of the admin are not tech savvy. So I think it's all these things that have been mentioned by previous are key points.
Thank you, Julie. Same question to you then, Abraham, around the critical enablers to be considered in the shift towards prevention.
Thanks, Oliver. Yeah, so I think it's interesting because I actually wrote a blog about this in a website recently. So I'll put that in the chat if people are interested. I think there are multiple critical enablers to actually for an effective integrated care system to actually function effectively. So I've sort of highlighted 4 key areas that I think that need to properly work. And that's based on my experience working within a healthcare system. So one is about, obviously, the point that I was making earlier on, which is really good digital and data infrastructure. So that is shared infrastructure across health and local government and the wider public sector to actually bring data together to not just understand the clinical needs of the population, but also the socioeconomic needs as well. And that's going beyond all of that, the sort of high-level tools that, like I was mentioning earlier on, like index of multiple deprivation that we're routinely been using for years and years. The second thing is bringing all of that digital and data infrastructure together requires really good governance and shared working between different organizations. In Kent, we have 200 GP practices, 12 district councils, 1 county council, 7 big NHS trusts, not to mention all of the hundreds of different care home providers that are dotted across Kent. And so that really makes it a real challenge around how we can actually have a collaborative data economy for data sharing. And so if we don't have the right sort of governance arrangements and sufficient leadership and capacity for information governance, then it's all going to still continue being fragmented and in Kent, we've made some progress, but we could have made more, I think, in my opinion. The third is that actually now there's a really big push, particularly from National Institute of Health research to actually encourage research around prevention, particularly with local authority public health teams. And so that we've sort of heeded the call in Kent, even though we didn't get any national funding for it. We have started building up that research function within our existing resource. And actually, we're making some progress around it, not just within our public health team, but also with other directorates like in social care, as well as in, say, our communities directorate, and also with voluntary organizations to start to build up that research capacity and capability, because you need to have those skills locally to try and do this rather than having to pay very expensive external providers to do that for you. And the fourth thing is that actually, no, in my opinion, and this is going back to an article that was generated by Professor. This is about building up the need for a complex system model of evidence for public health. I think that increasingly I'm seeing that linear cause and effect, that if you did this particular intervention, that's going to improve outcomes, is no longer the case. We're increasingly working in a complex system that we're having to address so many different issues, not just around the different socioeconomic factors, but also a very uncertain financial climate in terms of planning and decision making. We have to take into account all these different factors, and so we have to put in a systems thinking lens, not just as William was mentioning around the importance of planning, but also how we're actually going to build the workforce to actually deliver that prevention. So I'll stop there. I'll put the link to my blog, which will sort of make it more clearer what I was just articulating just now.
Thank you very much, Abraham. And Sarah, same question to you around the critical enablers.
So I mean, I guess I was obviously quite negative in my kind of presentation earlier. So I guess many of the enablers will be flipping most of that. But beyond the kind of, there need to be a clear vision, which I think that an enabler being very clear on what exactly areas are trying to achieve and why through prevention. I think there are opportunities in terms of local leadership and building local leadership capabilities for prevention. Some areas are doing this really well already, and that's often areas where local leaders are making the decision to just get on and do it. And I think that's basically one of the biggest enablers where we're already seeing that happen. At a national level, I think the other thing that would be helpful would be an enabler to kind of focus on addressing the barriers to change, and tackling barriers that are preventing kind of the well-evidenced approaches from being adopted universally across England. So this oft-cited idea of taking the best of the NHS to the rest of the NHS, really focusing on this rather than the kind of the shiny and the new, committing to sustainable investment, creating accountability, and a real focus on equipping frontline teams with the practical tools and support they need to kind of actually get this stuff to happen.
Thank you, Sarah. I didn't find your analysis negative. I think that it's really interesting actually, because I think from what William was saying, you know, we've got a lot of the wherewithal already there. It's just a question of taking the action from what information tells you, and those statistics on recall are fascinating. William, just over to you quickly for some reflections on enablers.
First one's money, and that's about where you choose to put your money. That's not about more money. That's about where you want to put your investment. Even if you just take that at a very basic level, if you've got a system in which you have 120 billion pounds and you're putting 23 billion pounds more into that, your marginal benefits are going to be far less than if you've got a system where you've got £1 billion in it and you put 100 million into it. And so there's just something about the economics of how you choose to move money around the system will make a greater difference, and therefore how people exercise their spending power will be really interesting rather than what they spend. Secondly, I think there's something interesting about change happens at the speed of trust, and so there's something really interesting in these change programs about relationships and how do you build those relationships. And even just on this webinar, you can hear people who have relationships and how much through trusting each other and working with each other over a long period of time you can make change happen. And that works at a leadership level, it works at a kind of, if you like, the sticky middle management level, but it also works at the frontline level. And then finally, I think really importantly, no one size fits all. So what you do is often exactly the same wherever you go in the system. How you do it has to be locally variable, and that's because no two areas are the same. If you take the wonderful bits of Kent that we've heard about today, the fact that you have coastal and rurality in there gives some real challenges, which then means it's completely different to London in how you look at that as a system, or Manchester. That doesn't mean that you can't do the what, you can't learn lessons from it, but understanding that what you can't do is say, Greater Manchester have done this, let's do this in Kent, or let's do this in Cornwall. There's more to be learned from Clacton in Cornwall than there is to learn from Manchester in, if you like, in Garstang, for example. So there's just something about no one size fits all, and we have to have that in our mind as local leaders.
Thank you very much. I'm going to now move on just to one question for each panel member, which we've sort of been thinking about during the course of your presentations. The first one is for Julie, and it's I was going to ask you about what the metronome was useful, but I'm not going to. But very curious. But
timing.
Oh, okay. Got it.
Down.
Got it.
Up,
Okay.
down.
I shall try that with my stepson in the morning. So just in terms of the increase in wearable devices, use of kind of remote monitoring, and how people can then access their own data. I'm just wondering how all of that fits in to the prevention agenda, and how big a change will that really make, given all the things you've been mentioning around sort of digital inclusion as well. So I wanted to understand kind of what impact you've kind of on a kind of reality basis you expect it to make.
Yeah, I think sort of tech has got a great role, and things like home testing, self-assessments as well, will really help with monitoring. But I would say that really they should be used as a follow-up if you've had a consultation, because a lot of people don't understand the basics. So when they're starting to use these products and services, unless they're going to read in detail or there's online videos to explain them, I think for something like the NHS health check, for instance, or workplace health checks, going and having that face-to-face consultation where you start to understand the impact of your health and well-being, your impact of your lifestyle on your health and well-being. Once you start to understand that, and little steps that you can make to make that difference, and are so important. So when you've got that information, we've seen such dramatic changes with how people sort of embrace the program and stick to it, because with motivation, within 3 months, a lot of people stop doing stuff. So I think the home testing is great for monitoring and for supporting and giving feedback, but also this data needs to go somewhere, because we need to be able to measure what are the outcomes from these long-term programs that people are going on. So I think there's a great opportunity, and things like genetics, I think over time will have a big impact. The genetic testing. Yes,
and that's of course part of the plan as well. Actually, it's really interesting. I've had my health check recently, and I know that if it hadn't been a consultation, if there hadn't been a follow-up, I wouldn't have done anything about it. That's just that's me being honest. So I do think sort of maintaining the program, but then taking the action after it is a really critical part of it.
Because it's once every 5 years at the moment. So people are often asking us, can I get a retest? Because that's what they want to do. They want to see if they're improving and what benefits they're getting from it. So I think it's not just a one-off.
Thank you. And Abraham, just a quick question for you on, so you've taught a lot, and you've now shared your papers, thank you very much, on the kind of issues around all the benefits of linking up data beyond just health and care with other agencies, monitoring, community sector, etc. And I'm just wondering what the kind of barriers are, from your experience of creating those links, getting those data sets to work, and how you might go about resolving them. You were saying you've already done some of that work in Kent, so I'm just keen to learn from your experience.
I mean, I'll be quite frank. The biggest problem is information governance. It's a lot of the data that we collect is all organization specific and within the ownership of individual organizations as data controllers. But what we don't have, and each organization will have their own capacity and capability of sorting out information governance for their organization. What we don't have is information governance operating at a system level and leadership, the leadership from information governance experts within a local health system to bring it all together. And with not having that in Kent, we were making some progress, but I think we stalled a bit. I think there's real opportunity for the NHS, particularly NHS and local government, to start to come together and start to really unpick these issues. Unless we unpick these particular issue around information governance, we will continue to operate parallel information infrastructure on digital and data, and we will not really have that effective integration both at a commissioning level as well as service delivery until the data is really joined up. Because at the moment, local government, we're looking at the data at a different lens. The NHS are looking at data at a different lens. We've made some progress around accessing NHS data. At least Public Health in Kent County Council has got access to our shared care record in the NHS, so we can do that. But the NHS can't really look into our data, particularly data sitting in districts. And just to bear in mind that councils actually collect a huge amount of data on vulnerability, on socioeconomic information, but it's not being shared because the statutory legislation that underpins the data collection it's not all on the same it's not on a level playing field. And there needs to be a national discussion to try and sort that out. But if we can get that leadership at IG, then it'll work. Sorry.
No, that's great. I'm going to link that actually to a question that's in the chat from Jonathan and Sarah William. I might ask you just to reflect a bit on that at the same time, which is the kind of how policy can be cross-departmental. And not just responsibility of one organisation. And obviously, if you look at the 10-year plan and the plans around prevention, they are all reliant on all of these different departments working together in glorious harmony to achieve some shared outcomes. And I'm just wondering sort of what your perspective is on that, and whether that's going to be perhaps sort of part of a solution, and how we might advise the government to think about that differently. Sarah, shall I come to you first?
Well, briefly, do I think it's part of the solution? I think it's a very, very large part of the solution, yes. When the government was elected, they were elected on this idea of having big missions of kind of all of government coming together and working together around a couple of really key areas, and one of them was health. And I think that was a really exciting idea that had a lot of potential. I do think it feels a little bit like that mission has somewhat gone missing. Reading through the 10-year health plan, there's a lot of kind of disparate ideas of a couple of different things that can happen for air pollution, a couple of things that can happen for obesity, very little actually that could happen for alcohol, but alcohol is mentioned. So some of the key biggest risk factors for ill health are kind of discussed, but there isn't really a kind of a common goal, and it's not really very broad. I don't think it's not really pushing in the same direction. So there's this idea, it's kind of a bit less fashionable these days, this idea around health in all policies. But basically that all policies should essentially consider health when being designed. How will this impact health, and what can be done by each government department and each policy area to improve health? And given that, and probably a lot of people here also agree with this because we all work in health policy or health related areas, given that I think health is really one of the most important purposes of government and one of the most valuable things in our society, that is what we should be focusing on. So I would like to see a return to kind of the original focus of the mission, and a bit more collective direction from government on this across all departments.
Thank you. And William, sort of same point to you.
So we did actually have a health in all policies government approach to health in about 1870. It was called the Public Health Act. I think there's huge value in going back to that. There's nothing in there about healthcare. It's about water, it's about clean air, it's about diet, it's about food security, etc. So really interesting. Two very brief thoughts on this. One is I don't underestimate that there's some really good stuff going on across government. Anybody who saw the kind of the water stuff that came out yesterday, the Independent Water Commission, there's 70 something references to public health, and that there was 0 in the NHS 10-year plan. The phrase public health appears in that writ large, and we need to grab things like that. There was also a Best Start in Life piece that came out this week. Last week, DEFRA had their food strategy, which actually is a lot of the stuff about the obesogenic environment. So I do think it doesn't have to be beautifully articulated as a single document. There are ways to knit and stitch together, I think, a lot of disparate things, which are very good. I think the other bit just to think about on this is, I'd say that whilst health in all policies is something we would absolutely champion and have championed, I think what you're seeing increasingly is economic development in all policies at the moment, and that's the real government mission. The 10-year plan was a love letter to the life sciences industry. Come and get us, spend your money in the UK and make that an economic development piece, with the view that creates jobs, that creates wealth, that reduces inequalities and allows you to do it. Whether that's true or not, I think I'd leave to economists and historians, but actually that's what in all policies at the moment we're seeing, which is growth in all policies. So I'd say there is a government cross-thinking, it's just not necessarily the way we want it.
Thank you, William. And I'm going to try and squeeze in one final question for a 20-second answer, if I can, which is around your views as a panel on the role of personalised care and support planning. So this is how individual patients support their own self-care, access health coaching, and other sort of support. So I'm just wondering how you feel that might be able to help drive the prevention agenda. Anyone?
Yeah, I mean, I've literally for the last 40 years, I think getting people to understand the impact of their health and their lifestyle on their well-being is so important. We had things in the 90s which were knowing your numbers. So I mean, it's the more you know about yourself, the better position you are in to know if things are not going right. So I think it is really up to the individuals to start to learn a little bit more about their own health and well-being.
Perfect. I think I'm going to leave it there because we are at time, and thank you, Abraham, for responding to that question in the chat as well. I just want to say a huge thank you to all of our speakers today. Absolutely fantastic input. We could have carried on for longer, but we do have to finish at 2 o'clock. Thank you also for sharing your blogs and information. We will write up a summary of this and publish it and send it out. I also want to thank Ali and Holly for organising the event from within PRSB. Thank you all for attending, and we will be running another one of these sessions very soon. We'll put some information out about that in the next couple of weeks. Thank you for your time, and we will see you all again soon. Thank you, everybody.